Surgery for lung cancer, there are multiple options. These include the old-fashioned thoracotomy, where we make a larger incision. We cut one of the ribs and allow a big enough incision to put our hands in the chest and remove the lung and the lymph nodes involved. Newer technologies allow us to do the same procedure through minimally invasive approaches. One is called a video-assisted thoracoscopic procedure, which is called VATS, and we're able to make smaller incisions and use a TV camera to assess the lung cancer and remove it through smaller incisions. And then one of the newest technologies is robotic-assisted thoracoscopic surgery, where we're able to actually use the robot to go in and remove patients' lungs with cancer, with the biggest incision being 1 inch. So it's a great involvement in our evolution in technology that allows us to do large procedures through very small holes. It usually results in a shorter hospital stay, less blood loss, quicker recovery, quicker return to work, and less pain. With these minimally invasive approaches, though, not all patients are candidates for these minimally invasive procedures due to the size of the tumor, the position of the tumor, so each person is individually assessed to come up with the best treatment plan. Some patients are not candidates for resection, so some of the alternatives may be chemo, radiation, or combination. One of the newer technologies is what's called SBRT, stereotactic whole body radiation therapy, and for patients who have poor lung function that would not tolerate a surgical resection, they're referred for consideration for one of these options. With surgery, the pulmonary function test that we obtain assess a patient's pulmonary reserve and how well they breathe before we do surgery, so it gives us an idea of how much lung can be resected at the time of surgery to be able to, one, get the cancer out fully, but also leave them enough lung that they can have quality of life after surgery. The standard of care for lung cancer is a lobectomy, meaning we take the lobe with the cancer out. There are 3 lobes in the right chest and there are 2 lobes in the left chest. So typically the lobe with the cancer comes out along with all the draining lymph nodes of that lobe. That's the standard of care for lung cancer and gives patients the best chance for cure. If it's spread to other parts of the body and/or it's spread into other lymph nodes within the chest, or what we call the mediastinum, which is the space between the lungs within the chest, then ultimately patients will often need some combination and/or chemo radiation without surgery. So the risk of lung surgery, there's the generic risk: infection, bleeding, heart attack, stroke, blood clots, pneumonia, dying. More specific to lung surgery, the risk include, which is a prolonged air leak, which means you might need to go home after surgery with a chest tube. Postoperative pneumonia or respiratory failure that could result in going to the ICU. Postoperative cardiac arrhythmias, atrial fibrillation or atrial flutter that might require new medications or other procedures, and the possibility that of going home on oxygen, whether that be short-term or long-term.